Okay, so I'm going to show you how to place an intravenous line. It's obviously something you're going to do every day and get very skilled at it. So usually when you're setting up in the morning or when you're setting up for any case, what you'll do is you'll assemble your IV boat before you go out to see the patient. And what that will consist of is some 4x4s, a sterile dressing, lidocaine with the TB syringe, the IV catheter that you're going to be using, alcohol to sterilize the skin, tourniquet, and a tape to secure the IV in place. So with all those things assembled, the first thing we're going to do is place the tourniquet. And it's important that you place the tourniquet high on the arm. Even though that you're likely going to start low, there's no reason not to place it up higher. It gets better venous engorgement of the venous structures. And also if you miss or have a poor target here, you can move up the arm rather than having to keep moving it up each time. So efficiency's sake, it helps to go above the AC with the tourniquet. You're going to place it fairly tightly. So you're going to spin it over and pull it in. Careful that you don't catch hairs in the patient's arm. And once again, you want it tight, because if you don't have it tight enough, then the veins are not going to be engorged enough, and you're more likely to go through the back wall, because the veins will just collapse as you go through them. So you want it nice and tight to get nice congestion of the venous structures. Then you're going to, before I even start the local, I alcohol the skin. And the reason for that is that it actually brings out contrast in the patient and kind of dilates a little bit more, kind of helps you get a better idea of where you're going. So I like to start in the hand. The reason for that is that I can move up the arm. I don't like the AC, because if you blow it, you pretty much lost the arm. And B, you could be blown in the AC and not realize it, and then you have a non-functional IV, which is not ideal. So as I alcohol the skin here, I'm looking, starting to see some good targets here. And what makes a good target is that you want a vessel that's plump and straight. So you can see here's one vessel. It's not really big, and it kind of turns. So if that's all I had, I might take it, but I got maybe a better one here. It's a little bigger, a little more tortuous. One here, a little more tortuous. This one's not a bad sized vein, but it's right on the cock of the wrist, so not an ideal location. So for this patient, I think I'm going to go right here, and the landing zone's, I think, adequate for the size IV that I need. I've got my local. I'm going to then pull the skin taut, because some people have some redundancy in the skin. By holding it like this and pulling tight, I can then get the skin tight. I'm going to inject a skin wheel and raise a nice wheel over the SOT. I'm going to slide this up so I don't stick myself. Then I'm going to get my needle, my catheter. This is a safety mechanism. All IVs used currently all have some safety mechanism. This is the release that releases the needle in, so you want to make sure not to touch that. Every hospital has a different system, so you should be familiar with the IVs once you get here. The way that it's best to hold this one is with your thumb and first finger on these side flanges, so that you're able to come in low profile from this direction, and you're not holding it like this, because then you can't see the drip chamber. So keep holding it on the sides, avoiding the top so I can see the flash, avoiding the white button so that I don't cause the premature release of the safety needle, then I'm ready to go. And then once again, holding it, I like to hold it like this, because then I have best control. I stabilize the skin. I come in fairly flat for a hand vein, and then I enter through the skin wheel, and then I get flash. This chamber will fill with blood. And then the important thing to note is you need to advance just a little bit more in the plane of the vessel once you've got flash. The reason for that is because the bevel and the catheter, there's a slight distance, so you actually need to make sure the catheter is all the way in the vein before you advance it off. Once I've advanced it, then I'm going to, with this finger, push this off into the vein. You see, one-handed off into the vein. And then once it's fully flush with the skin, then I can release. You can release the tourniquet before you release the safety. That way you will bleed less. Hold pressure, disconnect, and then connect your IV in. Once IV is connected, you're going to secure it and make sure you have a gentle loop that's not too tight to obstruct flow, but not big enough that it can get pulled out. Once again, when you're starting, it's best to go with a small IV. This is a 20 gauge. A running 20 gauge is much better than a blown 18 or 16. So go with a smaller size initially, and then once you get more practice, you can move up to a bigger IV. Another good spot to look for when you're having difficulty finding veins, often there's a vein here called the intern vein. That's a good one. The forearm's not a bad spot, and then the AC, if you have to, is another location that you can place in patients. The last thing to note is that if you're having trouble, you can use an ultrasound to find some of the deeper veins, and also putting a blood pressure cuff on for a couple of minutes at 300 millimeters of mercury may also give better engorgement of the venous plexus or venous apparatus, which might improve your odds. Last thing, check both sides. You'll be amazed how often one side has no veins. You switch to the other arm and you have great targets. So pick your best targets to make your best chances at success. Thanks. Okay, so I'm going to demonstrate the placement of an arterial line here. The model that I'm going to be using is a radial arterial line model, but this arterial line is going to be also placed femorally, which is a different technique, which I will not talk about today. But most often you'll be using the radial artery as your primary cannulation site. So the first thing you need to do is assemble the equipment that you're going to use. Most often you're going to use a Arrow radial artery cannulation set. It has the wire in it, and it is the easiest to use. We'll need some alcohol to clean the skin, lidocaine with a TB syringe if you're going to place the arterial line awake. If you do it post-induction, you do not need the lidocaine. 4x4s, a dressing taped to it to secure it. If the patient will be going to the intensive care unit post-op, you may need to suture the arterial line in, and obviously you'll need some way to transduce the arterial line with the pressure bag and transducer. So I'm going to start by alcoholing the patient's wrist. And if you notice the way that the wrist is, you really want it in extension. This is already in pretty good position, but we do have positioners that will put the patient's wrist in extension and allows the radial artery to be more stable because it is actually a fairly movable structure. We'll assume this is a awake patient, so after we've drawn up our lidocaine, we're going to inject a small wheel. And the important thing to note about inserting the local is that you're going to palpate the artery, and then you're going to raise a wheel, ideally on each side and up and over the insertion site. That allows a nice big wheel, you can rub it in. That allows for anesthesia on this on the skin, but also if you get around the vessel itself, it may prevent vasospasm just a little. So then you're going to spread it. Notice I did not pull back before I injected. I'm using 2/10 of a cc. If I injected that all into the vessel, nothing's going to happen, so you don't need to pull back. That's more of an old school teaching. When you're using small volumes, you don't need to pull back. It's just waste time and efficiency. Going to open the kit, and the first thing that's important to note is you're going to decap it and make sure that this is actually on. I can't tell you the times that I've seen people try and put it in like this when they've pulled this thing off. Obviously it doesn't work if you don't have a catheter to place into the artery. Next thing you want to know is to actually advance the wire down, make sure the wire goes in and out smoothly, and then put it fully back into its locked position back here. Then you're going to hold it like this, where you're holding the catheter and the introducer apparatus in one hand, so you can keep that together. And I'm going to place the bevel up. I don't know if you can tell the bevel's up. And then I'm going to palpate the artery again. Now the important thing to do is take a moment to actually really get a sense of where that artery is, because the arteries are actually quite small and the arteries move in under the skin. So you really want to be get a sense of right where the dead center is, and sometimes by rolling it back and forth, just kind of get the sense that you're dead on right there. And then once you're there, then you're going to palpate, stabilize, and insert. And if you look at the angle I'm going in, it's a little, it's not 45 degrees, maybe about 30 degrees. I'm going to go in until I get flash, and then you will see blood climbing up the catheter. And if it's arterial, it's going to climb right up. If it's venous, it'll probably fill slowly. So you want to see a nice fill. And then what you can do is drop your angle down, and then you can advance the wire off. And the important thing to note is this black mark, that's when the wire is actually going out of the catheter. So if you get to this point and you start feeling resistance, you're not in, so you need to reposition. But if it goes smoothly, then advance the wire, and then you're going to then kind of spin this off as it goes down till it's hubbed. And now in order to prevent making a big mess, you can distally occlude, or approximately occlude the artery here, and then pull out the wire. Fortunately, the wire is through the needle, so that's somewhat of a protected sharp, but still be careful with that. Connect your transducer to the catheter, and then you can secure it in place and tape it in. One technique that I'm going to demonstrate that's different than this is the through and through technique. Let me just quickly reload this and I'll show you the technique of through and through. So when you actually have trouble placing the catheter, it can be useful. So once again, going to palpate the artery, going to go, and so you get flash, advance the wire, but it kind of hangs right here. It's just not going. So basically what you can do there is then just advance the catheter through, advance the catheter through and through, pull out the wire, snip it here, and then just use the wire, pull back the catheter till you get good arterial flow, and then advance the needle in. So what's happened is, the idea is you've gone through the back wall, and as you pull out, you get full flow, put the wire in, and then advance it back off. That's a technique you may need to use sometimes when they have a lot of calcium in the artery, and it's difficult in placing. And once again, you know there's a problem when this black line goes down and you feel crunchy. It's never going to work by just trying to stick it in. You've always got to either pull out and go again, or do the through and through technique. And once again, you may need to suture it in place if the patient's going to the care unit. If not, just secure it up really well, and you're ready to go. One last technique you can do, which I won't demonstrate, but you can actually do this under ultrasound if needed, where you visualize the artery. And then the third technique when you're having difficulty is you can get the Doppler for the pulse, and it helps guide you when you are having a hard placement. Thanks.